Now, our first speaker today is familiar to all of us, Dr. Kamal Masaki, everyone's favorite geriatrician. She is also the soon-to-be director of the Midi Medical School on Healthy Aging when I retire in July. And she's going to talk to us about frailty and how to avoid it. Please welcome Kamal.
Good morning, ladies and gentlemen. I'm really happy to be back with you again. So I think you've heard me talk at every single session. I hope you're not tired of me yet. Today my topic is maintaining strength and avoiding frailty. So these are my learning objectives. I'll talk about the definition of frailty, the epidemiology, risk factors and consequences, screening and assessment, prevention and treatment, and then finally talk a little bit about new models of care that are coming out in the United States. Now, when I talk about definition, most people say, why bother to tell me about this? Isn't it pretty obvious? Sometimes it is. I think there are some people who are frail where all of us would just look at them and agree, this is a frail person. But it's more subtle than that. And whenever we do research in anything, we want to make sure we're doing it in a consistent way. So we want to make sure we're defining it in the same way so we can look at risk factors, causes, things like that. So in general, this is a very general definition of frailty. It's a syndrome of physiological decline. Usually happens in late life, but it could happen earlier. And it's characterized by a marked vulnerability to adverse health outcomes. These are people who are less able to withstand the stresses of life, injury, illness, hospitalization, things like that. And it's a very hallmark geriatric syndrome. It changes the course of people's lives, very much so. It's a forerunner to many other things happening to that person. That's why we always say prevention is so much better. So let me start out by what it's not. It is not defined by age alone. All of us know people who are in their 80s, 90s, and even sometimes beyond, who are really healthy and not at all frail. In fact, I know some people in their 80s and 90s who run marathons. They do things that I've never been able to do my entire life. So it's not just an aging issue. It's not the same thing as disability or comorbidity or chronic illness. It's more than that. It has multiple causes and contributors. It's characterized by a decrease in strength and endurance, and reduced physiological function and reserve in many of our organ systems. Now, unfortunately, this is a pretty common condition, and it's more common among people of older ages. The prevalence is anywhere between 4 to 16%, depending on the study, in the US population over the age of 65. And there are certain populations that are more vulnerable. So for example, older patients with cancer, prevalence of frailty is 43%, very high. Pre-frailty, this is an area where we're really focusing. We want to focus on these people to avoid becoming frail. Pre-frailty is actually quite common, 28% to 44% range. Unfortunately, ladies, we live longer, but we are also likely to live frailer. So frailty is definitely more common in women than it is in men. We see higher rates when people include cognitive dysfunction in the definition or psychosocial problems in the definition of frailty. Again, aging is certainly a risk factor. So over the age of 90, 24% have frailty. When we look at over 95, it's 40%. So these are the risk factors. Age is the common risk factor that we see. Lower educational level is also a risk factor for frailty. Part of this may be because with lower education, people also adopt poorer lifestyles through their entire lives, and that may contribute. Smoking is really bad. We always say that, and fortunately, among older age, most people have stopped smoking. It's very rare actually to find a current smoker in older age, but it would have been better if they had never smoked at all. Current use of postmenopausal female hormones is also a risk factor as well. African American or Hispanic ancestry, not being married is a risk factor. Depression is a huge risk factor, and then intellectual disability as well. Now, those of you who came to my talk last year, I spoke about basically the hazards of hospitalization. When you're going from the hospital to home, you're trying to get home, you're on a tightrope. The hospital is not a great place for people. And this is what we find. As people are navigating this complicated environment of the hospital, there are many things waiting to trip you up and push you over into frailty. In fact, many people become frail after a hospitalization. So something to really be careful about, and I think hospitals are trying to do earlier rehab, earlier discharges, partly to avoid this frailty syndrome that follows after. The consequences can be quite serious. Frailty has been linked to increased risk of mortality. The Women's Health Initiative, which was a very large study done throughout the United States in 40 centers, including Hawaii, by the way. We had a clinical center here in Hawaii. It showed that 70% increased risk was associated with frailty. 70% increased risk in mortality. There have been other studies of men that have shown that actually they have double the risk. If you're frail, you have double the risk of dying. Some European studies have found even 3 to 5 times the risk with frailty. Also, people who are frail are more likely to be in the hospital and are more likely to be in a nursing home or a care home. Now, you might tell me, I just said hospitalization increases risk of frailty. The opposite is also true. Frailty increases the risk of hospitalization. These are some other possible consequences. Falls, fractures. The most devastating of the fractures, of course, is hip fracture. Because many people who fall, older people who fall who get hip fracture, we know the recovery can be very difficult for them. And it's more difficult if they're frail to start with. Incontinence, delirium, or an acute confusional state. Again, most commonly in the hospital, but it could happen with other illness. Patients who are frail are more likely to have complications and poor outcomes of surgery or hospitalization, and often this will lead to functional decline and disability. Now, there are 2 concepts of frailty that have been put forward. Actually, there are numerous definitions, but these are the 2 sort of major concepts. The first one is called the frailty phenotype, or physical frailty. What is phenotype? The word phenotype means the observable characteristics of a patient resulting from the interaction between their genes and their environment. So part of it is genetic, but it's not all genetic. We can't use that excuse saying, oh, it's in my genes, I can't do anything about it. There's definitely things that we can do with our lifestyle that can change the genetic makeup. The second theory is the deficit accumulation or index frailty theory. This is where they say if you have a combination of illnesses, social situations, cognitive problems, and disabilities, together they form a constellation of syndrome, which is frailty. So I'll start with the first one, which is called the frailty phenotype. This is physical frailty from multi-system biological decline. And there are 5 factors that we look at specifically. The first one is weight loss. More than 5% in the past year. We don't put a number on it because it makes a huge difference where you start, right? So if somebody is 90 pounds to start, even a few pounds could be a big percentage, whereas if somebody is 180 pounds, it would be a big difference. So it's really percentage of body weight that we're more concerned about. Exhaustion, weakness, and we define this by decrease in hand grip strength, which we can test. A slow walking speed, which is defined as over 6 to 7 seconds to walk 15 feet, and decreased physical activity. So we add up the score. Everybody gets a score for each of these. So we add up the score, and 0 is normal, 1 to 2 is the pre-frail. These are people at risk, and then 3 to 5 is frailty. So that's the definition. And again, we really want to focus on the frail, but we want to focus on the pre-frail to prevent them from moving over into frailty. The second theory is the deficit accumulation. The advantage of this is actually you don't even need to examine a patient. You could do a medical record review and define frailty based on medical records. So this is over 20 questions, which lists illnesses, a bunch of social questions, cognitive status, functional status, and you can actually derive this, as I said, the score. So this is what we see with the frailty spectrum, and I'm going to try and use this mouse. So here we have performance starting out at good, and as you go down, the performance declines. And here we have what we call homeostatic mechanisms. I want to remind you what homeostasis is. Homeostasis is your body trying to keep everything in equilibrium. So when something happens, when you get a fever, when your heart rate goes up or down, when your blood pressure goes up or down, anything, your breathing, your body tries hard to bring it back down to normal. There's a lot of compensatory mechanisms that we have. And again, the people up here have good homeostatic mechanisms, and as you go down, it's getting less and less. And here on this x-axis, we've got age. So starting out with younger ages and going out to older ages. So I'm going to show you these two lines here. So this line is normal aging. So unfortunately, we do see that your performance and your homeostatic mechanisms do go down even with normal aging. But if you are aging well, you can go through your entire lifespan and not get into this frailty definition. This is the frailty phenotype, where you can see that they are declining sooner than normal aging and getting into this is normal here. Here we have pre-frail, so they're getting into it earlier and having a longer time in the pre-frail, and then having a chance of getting into actual frailty. And then down here is actually the complications of frailty. So that is more end stage. Here we see when the pre-frail, whenever you have external stressors, they might dip. So they might dip, but they don't quite get into frailty yet. But if you have it enough times, you can see where they might drop. Here already, people who are frail, they don't respond well to external stressors. And you notice when an external stressor happens, they don't get back to normal. They drop a little bit. The next stressor will drop them even more. So again, that's a cycle we don't want to get into. So I do think it's important to screen for frailty. And there have been multiple assessment tools that are out there. Actually, when I researched this topic, I was surprised to find there are over 70 tools out there, and not all of them match. Fortunately, there's good correlation between the tools, but I think to ask primary care physicians to screen, we need to keep things simple. Because if we ask them to do very complicated things, they don't have the time and they're not going to do it. So I always believe in simple. Common measures that are used are physical function, gait speed, and cognitive function. This is a very simple screening tool that I think any primary care physician can use. It's called the FRAIL scale. We love mnemonics in medicine. So the F is for fatigue, and it's just a simple question. Have you felt fatigue most or all of the time over the past month? The R is for resistance. Do you have difficulty climbing a flight of stairs? The A is for ambulation or walking. Do you have difficulty walking 1 block? I is for illnesses. Do you have any illnesses? Now, many older people will have chronic illnesses, but that doesn't necessarily mean they're frail. Again, they might be very well controlled and there might be just 1 or 2. So you get a point if there's 5 chronic illnesses. And then L is for weight loss. Have you lost more than 5% of your body weight in the past year? You get 1 point for each of these answers. And 0, a total score of 0 means it's somebody who's robust no matter what their age. 1 to 2 is pre-frail, and 3 to 5 is frail. So this has never happened to me. Nobody asks me this. I'm still waiting. I tell myself, actually a little bit extra weight is good in older age to avoid frailty. I tell myself maybe that's why. Nobody's buying it, right? What about frailty and cognitive function? Well, frailty is associated with increased risk of mild cognitive function and cognitive decline as well, and dementia as well. On the other side, cognitive dysfunction is also increasing the risk of frailty. So we see this is a vicious cycle people get into. We know that people who are cognitively impaired are also more risk for getting frail. So this is what happens in the body with frailty. There are some hormonal changes that happen with age. There's a decrease in the growth hormone, which leads to lower strength and decreased mobility. There's a decrease in dehydroepiandrosterone sulfate. Can you believe I said that? Let's just use DHEAS, which causes a decrease in muscle mass. There's an increase in cortisol levels. Cortisol is the stress hormone. So whenever our body is undergoing stress, you get spikes in the cortisol level, which impacts muscle as well as the immune system. We have decreased sex hormones. In women, it's a more sudden drop at menopause, but even in men, there's a gradual decline through age. And there's decrease in vitamin D, which has effects on lower muscle strength and increase in falls. There's also effects of age on inflammation in the immune system. We see higher levels of inflammatory markers in the blood of older people. The immune system activation actually triggers clotting cascade, which is why we see higher rates of heart disease and stroke in older people as well. And we have inadequate response to vaccinations. That's kind of ironic, right? Virginia, I completely agree with you. Everybody should have taken the flu shot. But the people who need it the most will also have the least immune response to it. In our nursing homes, we see that a lot. Those are the frailest people, right? The frailest, the sickest people in nursing homes. We try really hard to have 100% immunization rates. We get close for patients. But they don't mount a very good immune response because they're frail. So actually what we tell our staff is staff immunization is more important because we don't want, and then visitors, we don't want visitors to bring it into them. We just want to expose them as little as possible because once they're exposed, it's very hard to get them out of it. The autonomic nervous system is kind of things that happen automatically without us thinking about it. Things like breathing, your heart rate, your blood pressure, digestion. It happens in the background. We're not even thinking about them at all. We see with age, there's a dysregulation in the autonomic nervous system, so with stress, it's harder to respond for older patients. So who should be screened? Everyone who's 70 years and older. Even younger, people who have chronic diseases might be frail. It's not just an age issue. So I think people with chronic diseases should have a screening as well. Unintentional weight loss, and anything else that's suggestive. So if we have any suspicion, you could see some of those screening tools are quite easy to do. So I think that's a good idea. A complete geriatric assessment is very helpful for these patients. A good history, including diet, weight, not just one weight, but serial weights to know about what their weight has been over time. Physical activity levels, whether they have energy, whether they have fatigue. Past medical illnesses and surgeries are important. A detailed medication review. You have heard me say this many, many, many times. With older patients, often medications are causing more problems than they're helping. A physical exam, including functional assessment. Some of the things we do to assess function, we have them do repeat chair stands. So I have someone sit in a chair without arms usually, and see how quickly can they get up, stand up 5 times consecutively, for example. Gait speed. Have them get up from a chair, walk across the room, turn around, walk back, and sit down in the chair. Just watching that can tell you a lot. Balance measures. That's really important because we want to make sure patients don't fall. There's a get up and go test, which is the one I just described, and that's one that's commonly done as part of a geriatric assessment. When we see patients who are frail, the first thing we want to do is look at a differential diagnosis. What else could this be that's mimicking frailty? Depression is a very common one, because people with depression will have low energy, low physical activity, might be losing weight because their appetite is gone. There's a lot of things we can do. So sometimes treating depression can reverse the frailty syndrome. Do they have anemia? Do they have nutritional deficiencies? Is there an underlying cancer? Is that something we should be looking for? Rheumatological diseases, endocrine diseases, cardiovascular, kidney, neurologic. Basically, we're doing a complete assessment of that person's body. There are some basic lab tests we suggest, a complete blood count, metabolic tests, things like electrolytes, kidney and liver function. Albumin is a protein, and a low level of albumin might suggest malnutrition or other factors. We do recommend doing a vitamin B12 level and a vitamin D level as well for people who are frail. Measuring thyroid hormones can be really incredible, because if you have low thyroid, that can, just a simple replacement can change the person's life and make them do very well. And then other tests based on what you find on your history and physical exam. So prevention and treatment are really important. The first step is always to establish goals of care. What is important to that person? And to know that, you have to talk to the patient and talk to their family and find out, because it's very different for each of us. You need to have priorities. What is important for that particular patient? Weigh the risks and benefits of everything you want to do. So some of the questions we ask ourselves is, does this patient want aggressive care? Do they want invasive tests? I have had patients tell me very clearly, please never do a colonoscopy on me again. I don't care. I don't want a colonoscopy, okay? So I have to take that into consideration. Sometimes maybe they need it and I have to explain, but then there's risks and benefits, and then the patient makes the decision along with the physician. So patient autonomy is what's really important, right? Each of us is in charge of our own bodies. The goals can really vary. I've had older patients tell me, prolong my life at all costs. If you need to put me on machines, that's what I want. On the other hand, more often I have people tell me, comfort and quality of life is more important to me than staying alive longer. So independence is important, quality of life is important, and if I don't have that, I don't want to be kept alive. We always ask some of these questions. Do you want to be resuscitated if your heart stops or you stop breathing? Do you want ICU care? ICU care comes with a lot of aggressive treatments and a lot of invasive and sometimes painful procedures. Now, for some patients, it can be life-saving, but other people want comfort and they don't want to be put into the ICU. So I ask very detailed questions when I talk to patients. I guess the bottom line is, just because you can do something doesn't mean you should do it. It should be a very thoughtful process and a thoughtful discussion with patient and family. It's important that patients share their goals of care with their family members and their physicians. We do have people who've told me what they want, and I always ask, have you talked to your children or your spouse? And they say, oh no, they don't want to hear anything like that. And I tell them, that's not really fair to them, because if there's a crisis, they won't really know what you want. So it's very important, even if it's a difficult conversation, and many children will tell them, Mom, Dad, I don't want to talk about this. It's important to say, let's just talk about it this once, so you know what I feel, and then that we're done with that conversation. Advanced healthcare directives are really important to do. We have, our next speaker is actually from Kokuamau, which is a palliative care organization here in Hawaii, and she's the director, and she's left a lot of wonderful resources on the table outside. So at the break, I encourage you to go and pick up some of these. This is a guide to advanced care planning. There's several others out there that you'll find very interesting. Making an advanced healthcare directive is critical. I've asked this question before, and I know most people in this room do have it. Having a durable power of attorney for healthcare. I think that's important too, because the Advanced Healthcare Directive cannot possibly cover every possible scenario. So having somebody you love and trust be sort of your voice when you're no longer able to speak is very important. POLST is the provider orders for life-sustaining treatment. I'll go over some more details of that in future slides. Give your doctor and your hospital copies of all of these documents. And please don't lock them away in your safety deposit box, because there might come a time when you really need them, so make sure that your loved ones have copies too. So these are some resources if you'd like help. The University of Hawaii Elder Law Program, we call it UHelp, is a very good resource. They provide workshops free. Their students do workshops for the public. And this is the Kokuamau website, which also has some wonderful resources, blank forms, a lot of information, a lot of education that you can get out of there. So this is a comparison of Advanced Directive and POLST. And POLST is usually in this bright green color, so it's printed on bright green colored paper. There's a good reason for that. It's so that when the EMS, let's say you call 911 and the ambulance comes to your house, they can find it easily because it's this fluorescent green color. It should be put in a place that's easy to find, like often on the refrigerator. Some people put it on the back of their front door, but somewhere where it's easy to find, again, not locked away. So this kind of compares the two. What is the purpose? Advanced directives express wishes for future end-of-life care, whereas the POLST is actually a portable medical order, which will be acted on right now if there's an emergency. Who needs it? Advanced directives, everyone over the age of 18 should have it, all adults. Whereas the POLST is really meant for seriously ill or medically frail patients. It's regardless of age. You could have someone who's 40 who might need a POLST, but in general, it's for people who have serious illnesses. The treatment focus is for the future in an advanced directive. It's just if you're unable to speak for yourself, your advanced directive says it for you. Whereas the POLST is right now. It's based on your current condition, not your future condition. Advanced directive is completed by the patient. POLST is by the doctor or advanced practice nurse, as well as the patient or sometimes their legal representative if the patient is unable to sign. Healthcare agent, yes, the advanced directive does give you the option of providing a durable power of attorney. The POLST does not. Both of them guide emergency room or emergency decisions, but EMS, the emergency medical services, will only honor the POLST. So for example, if somebody says, I don't want to be resuscitated if my heart stops, if I stop breathing. If the Ambulance comes to your house. If you have a POLST that specifically says no CPR, they will not do CPR. On the other hand, if you don't have it, they will do it and take you to the emergency room, and then there's clarification later. So it's really good for some patients, frail patients, to have a POLST, because sometimes the family will come to the emergency room and say, Mom never wanted that. Well, it already happened. So you want to prevent things like that from happening. So prevention of frailty. Exercise is really, really important. I think there's an optional exercise group today, right? Yeah. So all of these types of exercise can be useful. Tai Chi is wonderful for balance. It's actually the most proven for prevention of falls. Muscle strengthening exercises, aerobic exercises, all of these can be important. Group exercises have actually been found to have additional benefit, and part of it might be the socialization, because we know socialization can also help many different outcomes. Exercise improves mobility, function, gait, bone mineral density, and just your overall sense of well-being. It decreases falls, it decreases rates of depression, and it's effective at all levels of frailty. So sometimes you'll see exercise classes that are seated exercise classes. So these people can't really walk, or maybe not walk very well, but you can still do chair exercises. So exercise of any level is useful. Nutrition is really important. So when we see weight loss, sometimes you have to be a bit of a detective to find out, why is this person losing weight? Could it be a medication side effect? Sometimes that's exactly what it is. Some of the Alzheimer's disease drugs, that's one of the reasons I stop them. First of all, they're not that effective. And second of all, people start losing weight. And the weight loss is more dangerous than anything else. So that's when I look very carefully and I stop the medications. Does the person have an untreated depression? That's something that we can certainly fix. Is it a denture problem or a tooth problem? Are they having difficulty chewing? Are they having trouble swallowing? Again, that's something we should be looking at. Sometimes it's as simple as meal preparation and shopping. The person cannot get out of the house very easily. You look in their refrigerator, it's empty. Well, of course they're going to be losing weight, right? So are they able to actually prepare their own meals? If not, maybe something like Meals on Wheels would help. This is a very touchy subject for a lot of people, unnecessary dietary restrictions. I have a lot of older patients who are very well educated, very well-meaning, and they're sticking to their healthy diet, which is low salt, low cholesterol, no sugar. That's great, but if they're losing weight, the first thing I do is I liberalize their diet and say you can eat anything you want. Because again, weight loss is more dangerous than having a slightly higher cholesterol or a slightly higher blood pressure, things like that. So I want them to basically, I'm giving them permission. You can eat cookies, ice cream, anything you want, anytime you want it. Don't you wish somebody would give you permission like that? But in general, balanced diet is really important. So this is the government's definition of what your plate should look like. They say eat the rainbow, right? So on the left side is fruits and vegetables. That should be half of your dietary consumption. This is protein. Again, it should be lean protein if possible, grains, and just very little dairy. So I think all of us could probably benefit from a healthy diet. 2 weeks ago, the snack was cookies, so I know it wasn't that healthy. But I think this week it's a healthy snack, right? Yeah. Okay. Sometimes for patients who are losing weight, nutritional supplements can provide additional protein and calories. We usually recommend this between meals, not instead of meals. Because otherwise, what they'll do is they'll have it instead of their meal, and then they won't eat the actual meal. So in between, sometimes just a half a can provide some additional calories that the person can really use. Vitamin D has been associated with reduction in falls, and it may improve your balance and preserve your strength. It's important for maintaining function of the muscle and nervous system. Now, unfortunately, studies of vitamin D and frailty have had very mixed results. So it's not just a simple thing to say everyone who's frail should take vitamin D. That's not really been proven. But we do say everyone should have adequate vitamin D in their diet. And a lot of older people don't. If you think about where we get our vitamin D, part of it is from our skin, from being out in sunlight. You don't need a lot of sunlight, by the way. It's like 15 minutes a day is more than enough. But people who are in nursing homes may not even get that much. The other part is in our diet. And a lot of it is coming from milk or dairy products. And a lot of older people don't get adequate milk or dairy because they're lactose intolerant. So you want to make sure that at least if they're not getting it in their diet, they're getting enough with supplements to maintain their adequate daily intake. Cognitive function, it's important to keep cognitively, mentally, socially active. And then medication review is really critical. And this is particularly important for pre-frail and frail patients. Side effects can contribute to frailty. Sometimes it's just a dosing issue. I think I've done a talk on medications for this group before. The same dose is not needed for older people as for middle-aged people. Often we can go with half the adult dose, or even sometimes 1/3 or even 1/4 of the adult dose, and it's effective. So we always have to weigh the risks and benefits. So across the continuum of patients, we see a lot of robust older patients who are really healthy, do not have chronic illness, do not have frailty. For them, we do want to treat any illnesses that come up and do appropriate screening and preventive care for these patients as well. So these are patients where we want to make sure that maybe they need cancer screening. Maybe they need screening for other diseases. Maybe we need to make sure that we check for diabetes and hypertension and cholesterol and treat all of those factors. Then when we get into the moderate to severe frailty, often less is more for those patients. Complications of testing are very common, and quality of life should be something we should be talking about with our patients. What defines quality of life for them? For severe frailty, we certainly should be considering palliative care. Palliative care is very appropriate, even in moderate frailty. Really, for any chronic illness, that's an option that should be brought up. The goal is to treat symptoms and to put comfort and quality of life as a priority for those patients. At the very end stages of life, hospice may be an option. And you need a prognosis of less than 6 months to be enrolled in hospice. That's actually a benefit that Medicare gives us if we want to use that. And the people who have used hospice have been so happy with it because it really helps guide your loved one through a more comfortable and dignified death if possible. And you don't need a specific diagnosis. We do need to give a diagnosis, but sometimes for an older person, we don't have a specific diagnosis in the sense of terminal cancer or heart failure or something like that. So something like failure to thrive, which is sort of the very definition of frailty, may qualify somebody for the hospice benefit as well. These are some treatments that have been found to be ineffective. Testosterone replacement. Now, testosterone does build muscle, right? So you say, why can't we use that for frailty? It's only been found to be effective if somebody's actually low in testosterone, not just for a frail person. Testosterone does increase muscle mass and strength, but it has some very bad side effects on the lipids, on blood pressure, and even on the prostate gland. Growth hormone has been tested, but actually it's been thought that the risks outweigh the benefits, so it's not used anymore. DHEAS supplements have not been found to be useful as well. And then female hormones after menopause, the Women's Health Initiative study showed very clearly that not only was it not protective, it actually caused a lot of harm. and women who took postmenopausal hormones should do so for the least time possible, the least dose possible, and should stop them as quickly as possible because of the many side effects. I always want to put in some of our own research into my talk. So this is the Kuakini Honolulu Heart Program and Honolulu-Asia Aging Study. It started in 1965 in 8,006 middle-aged Japanese men, and we've been following those men for 55 years. Pretty amazing. The Honolulu-Asia Aging Study started in 1991 to study cognitive function and other disability and diseases of aging. Currently, by the way, from these 8,006, we have about 40 still alive, and the youngest is 100 years old. It's the most amazing group of men. So this is a project that one of my fellows did last year, and this is the percentage of people who develop new functional impairment. And at baseline, we tested the hand grip. So the blue was the strongest, the orange was the middle group, and the gray was the weakest group in hand grip. And then we followed them for 3 years, for 6 years, and for 10 years. And you can see the hand grip strongly predicted functional decline over 3 years, over 6 years, over 10 years. These p-values are highly statistically significant. This is being presented today. There's a conference going on, the American College of Physicians, by one of my current fellows, and looking specifically at depression and whether it predicts activities of daily living or functional impairment. And again, showing this is no depression in green and depression in blue, and showing, again, much more decline at 3 years and at 6 years among those who have depression. These are some new models of care: comprehensive geriatric assessment with a team, doing home visits for environmental modification, optimizing hearing, vision, doing rehabilitation early, and providing social supports. PACE is the program of all-inclusive care of the elderly. These are patients who are nursing home level but are able to stay at home with the PACE program. Unfortunately, Hawaii does not have this program available. We did, but no longer. Hospital care, we know, increases frailty. So some places have created ACE units, acute care for the elderly, where the environment provides early mobility, constant reorientation with a team, and looking at medications very carefully. We've had very good outcomes with these units, but unfortunately, again, Hawaii does not have any. I do want to point out, Kaiser created this wonderful day program for hospital patients, but only for those with dementia. What they do is, while the patients with dementia are in the hospital, they take them to this day room where they keep them socially engaged, physically active, awake. So they're not sleeping all day and up all night, and it really has been found to be effective to prevent delirium and other complications. So in summary then, frailty is a state of vulnerability with increased risk for adverse outcomes, decline, and mortality. There are multiple risk factors, so screening is very important, and setting goals of care with patients and families is really critical. So I'm going to stop here and take some questions, but before I take questions, actually, I'd like Virginia to come up here.
I'm the example.
She screens all the slides, so I had to sneak these next few slides by her. She doesn't even know about them. So as you know, I'm going to be taking over the mini medical school. I wanted to show you some differences between Virginia and me. I think we'd all agree that Virginia is the original social butterfly. I'm totally an introvert and shy. Another difference. I think we'll all agree she's pretty extraordinary. I'm pretty ordinary. A third difference. Virginia is sane. She likes to play tennis. I like roller coasters. Some people have called that pretty insane. But we do have a few similarities. We both love science. We're both interested in aging. We both love to laugh. And finally, some people say both of us are a pain in the neck. Thank you, Virginia, for everything you've done. And everyone, please wish me luck.
Mahalo, Kamal.